بقينا كام؟
Assalamu alaikum. Abnormal Uterine Bleeding lecture. In fact, we know that there is a normal uterine bleeding, which is the menstruation, and this uterine bleeding is described in certain patterns. The first pattern is the frequency, the second pattern is duration, the third pattern is amount of flow or flow. And these patterns, frequency, duration, and amount, describes any bleeding, especially the normal uterine bleeding, which is the cyclic menstruation. You know that frequency is 21 days to 35 days, the duration from 2 days to 8 days, duration of the menses itself, and the flow of the menses is from 10 millimeter to 80 millimeter. And of course, we cannot measure exactly the amount of bleeding during menstruation, but we can ask the patient about how many napkins is she used by day. So these patterns, which are frequency, duration, and flow or amount, are used to describe the bleeding by the uterine cavity. Now we came to the definition of abnormal uterine bleeding. Of course, any uterine bleeding that is different from the normal one using these patterns, then we can define abnormal uterine bleeding as bleeding from the uterine corpus that is abnormal in frequency and or duration and or amount. There are certain terminologies which were used. Now it's all terminology like menorrhagia, metrorrhagia, polymenorrhea, oligomenorrhea, which are changing in the patterns. If they are changing the pattern of the flow, increasing, it means menorrhagia. Increasing flow means menorrhagia. Decreasing flow means hypomenorrhea. Increasing in the frequency means polymenorrhea. Decreasing in the frequency means oligomenorrhea. Increasing in the duration without amount is given the terminology of menostaxis, for example. So these terminology were used, but now it's considered to be old terminologies. We have to differentiate between abnormal uterine bleeding and dysfunctional uterine bleeding. In fact, the only differentiation they both are the same in definition. They both are uterine bleeding or bleeding from the uterine cavity that is different from normal one regarding frequency and or duration and or amount. In absence of a cause or a mass, that means dysfunctional bleeding, and it is considered to be misleading terms, because how can be sure that there is no cause or a mass? So also dysfunctional uterine bleeding, some said it is a misleading terms. So there are new classification of abnormal uterine bleeding according to the International Federation of Gynecology and Obstetrics (FIGO), and it is a Palmer-Cohen classification. Palmer-Cohen is an acronym. Each letter stands for a cause of bleeding: polyp, adenomyosis, leiomyoma, malignancy, and the other Cohen stands for coagulopathy, ovulatory disorders, endometrium, iatrogenic, and not yet classified. Of course, there are differential diagnoses according to the age of the female that suffers abnormal uterine bleeding. Of course, with certain group of age comes certain causes. As we see in the prepubertal child below 10 years, there are certain causes that may cause abnormal uterine bleeding. Most common are precocious puberty and foreign bodies. In the adolescent group, the abnormal uterine bleeding is always caused by dysfunctional uterine bleeding or anovulatory cycles. And the other groups like premenopausal and postmenopausal, we have to consider an organic disease, and we have to consider the malignant or fibroid or neoplastic origin. In the postmenopausal, the most common cause is vaginal atrophy, endometrial carcinoma, and hormonal replacement therapy. What we do in a case of abnormal uterine bleeding: first, the physical examination. After taking a good history from the patient to exclude any hematological disease, you have to physically examine the patient, the vital measures, the obesity, hirsutism, thyroid dysfunction. We have to confirm the bleeding that from the GI tract by speculum examination and by manual examination. And of course, we have to do imaging. Pelvic ultrasound is important and mandatory in any case for abnormal uterine bleeding in order to exclude any mass in the genital tract that may cause bleeding or polyp. We can use also other imaging like MRI. We can use endoscopies like hysteroscopy. Biopsy is very important, especially in the age of premenopausal and postmenopausal bleeding, either pap smear or cervical biopsy, endometrial biopsy. In the management, we have to assess the severity of the condition, stability of the patient, severity of the bleeding, and the desire of future fertility. The hormonal treatment of these conditions is either conjugated estrogen, but estrogen alone is not used regularly, only used as a gel to induce the vaginal maturation, and it shouldn't be used alone for fear of cancer. So it has to be combined with progesterone. So combined oral contraceptive can be used as a management of bleeding. Progesterone only can be used because progesterone over a long time can induce endometrial atrophy and stop bleeding. We can use GnRH analog. Danazol has not been used because it's dangerous side effects. Can use the antifibrinolytics like tranexamic acid. Also, we can use other products that induce endothelial stabilization. There are certain surgical management options like dilatation curettage, which is diagnostic and therapeutic in certain cases. Endometrial ablation by hysteroscopy can be used. Uterine artery embolization by radiological intervention can be used. And radical management is hysterectomy. Thank you.